Here is what your doctor's office will look like in 2030 and what you should ask for now. I am going to give you a physician's honest forecast for the next 5 years in clinical AI. What changes in documentation? What changes in diagnosis? What changes in how specialists relate to primary care? What changes in how practices like mine operate financially? And what the one question is that you should ask any healthcare provider about their AI tools. This is the series finale, and it ends with a preview of where we go next. Before I look forward, I want to briefly look back at what this series has covered because I think the accumulation matters. We started with the basic problem, physicians spending more than half their working hours in the EHR, building the case that this is not a physician behavior problem but an operating system gap. We walked inside Tsinghua's Agent Hospital, where AI doctors trained on 500,000 synthetic patients and achieved performance that rivals a physician at the board exam level. We looked at the AI hospital benchmark, which showed that model performance on static QA drops by more than 50% when the model has to actually conduct a dynamic patient conversation, the hardest insight in the series. We whiteboarded the MedicalOS architecture, the compiler analogy, the React loop, the standard library grounding, the first make then verify principle. We went deep on the OpenClaw Hospital infrastructure, the permission model, the document-centric interaction, the manifest-guided longitudinal memory, the composable skill library. We read the Google, Microsoft, and OpenAI announcements with a physician's eye and separated the real progress from the press release overclaiming. We looked at the long-tail patient, the complex, multi-system, longitudinal case that the current EHR simply was not built for, and that Agentic AI finally addresses architecturally. We built the Pravida working playbook. 5 workflow zones, agent types, physician review gates, and the Pravida AI operating system map. And we did the safety episode. The red lines, the 5 failure modes, the 3-question framework, the automation bias problem. That is 10 weeks of work, and I want to use the final episode to synthesize it into a forward-looking view that you can actually use to make decisions. Whether you are a clinician thinking about how to position your practice, a healthcare operator thinking about technology investment, or a patient trying to understand what to expect from the healthcare system you depend on, I want to leave you with a clear-eyed roadmap. I am going to make specific predictions across 6 domains. I am going to resist the temptation to hedge everything into meaninglessness. I think that is the intellectually dishonest way to do forecasting. Some of these predictions will be wrong. That is the nature of prediction. But I would rather give you a specific, arguable position than a set of safe non-commitments. Domain 1, documentation. By 2028, I predict that the majority of visit documentation in U.S. outpatient practices that have adopted ambient AI scribes will be AI-generated first and physician-reviewed second, rather than physician-generated first. The tools for this exist today. Abridge, Ambience, DeepScribe, Suki, and others are already deployed at major health systems. The remaining barrier is EHR integration maturity and adoption friction among older clinicians, not technology capability. By 2030, documentation in well-integrated practices will not feel like a distinct task. It will be a byproduct of the clinical encounter, the way a visit recording used to require a separate recorder, and now it happens automatically on any device. The physician will review and sign. The generation will be invisible. The implications: medical scribes as a job category will contract significantly by 2030. The human value in documentation will shift to review and clinical synthesis, not generation. Domain 2, diagnosis. By 2028, multi-agent diagnostic orchestration tools, in the tradition of the AI hospital dispute resolution mechanism and the Microsoft MAI-DxO architecture, will be standard in complex diagnostic pathways at academic medical centers. Not replacing physician diagnostic reasoning, but augmenting it for cases that cross multiple specialties or that present atypically. By 2030, a physician who is working on a difficult diagnostic case without consulting an AI differential generator will be in the minority, the same way a physician who reads ECGs without algorithmic support is now in the minority. This does not diminish clinical expertise. It amplifies it. The physician brings judgment, clinical observation, and patient relationship. The AI brings recall, pattern recognition across millions of cases, and structured comparison to benchmarks. What I am not predicting: autonomous AI diagnosis as a standard of care for primary care in the US by 2030. The regulatory pathway, the liability structure, and the clinical outcome evidence are not there yet. This is a decision support tool, not a replacement. Domain 3, longitudinal care. This is the prediction I am most confident in. By 2028, longitudinal patient records managed by manifest-guided memory architectures, the approach described in the OpenClaw Hospital paper, will be demonstrably better for complex patient management than current flat EHR systems, and health systems that adopt them will show measurable improvements in care coordination quality. The MIMIC-4 benchmark result, 21% higher recall on complex longitudinal queries, 2.2 times higher precision, is not a marginal improvement. It is a structural advantage. For patients with chronic conditions, complex multi-specialty histories, and long-term care relationships, the manifest-guided architecture changes what the physician can know at the point of care. That translates into better decisions, fewer missed diagnoses, and more consistent follow-through on long-term plans. By 2030, patients will expect their healthcare providers to have access to a coherent longitudinal record of their health history, not a fragmented collection of notes across 7 health systems. Those practices that have built the infrastructure will be differentiated. Those that have not will be conspicuous in their absence. Domain 4, federal contracting and healthcare compliance. This is a domain-specific prediction for practices operating in the public contracting space, which is relevant to Pravida's development as a company. By 2027, practices that can demonstrate systematic outcome tracking, protocol-level quality documentation, and audit-ready AI-assisted workflows will be at a significant advantage in federal healthcare contracting, including 8A small business contracting, VA-adjacent work, and DoD healthcare provider agreements. The compliance and documentation requirements for federal healthcare contracting are structured and standardized in a way that is exceptionally well-suited to agentic documentation. The same audit trail, document-centric, version-controlled workflow that the OpenClaw architecture builds for clinical safety purposes maps almost exactly to the documentation requirements for federal contract compliance. A practice that builds the clinical OS can turn the federal compliance documentation into an automated byproduct. For any physician practice with entrepreneurial ambitions in the public sector healthcare market, the investment in agentic clinical infrastructure is not just a clinical improvement, it is a business positioning move. Domain 5, content marketing and patient education. I will be direct about something. This YouTube series is itself a product of the thesis I am describing. The discipline of explaining complex clinical AI to a broad audience, physicians, healthcare operators, engaged patients, is valuable, and it compounds. Every episode builds credibility, reaches new audiences, and creates the patient education asset that a practice like Pravida needs to serve an increasingly informed patient population. By 2028, AI-assisted content generation that is grounded in a physician's clinical practice data, the same practice analytics loop I described in Episode 8, will allow physician content creators to produce educational content at a volume and relevance that was previously impossible for a solo or small group practice. The content will be authentic because it is grounded in real clinical outcomes and real clinical reasoning. The production will be amplified because the generation layer is AI-assisted. Physicians who understand this feedback loop and build toward it will have a differentiated platform by 2030. Physicians who are waiting for a media company to find them will be waiting indefinitely. Domain 6, medical education. The Agent Hospital finding that AI doctors can train on 10,000 synthetic patients in days and reach board exam level performance in specific domains will, by 2030, fundamentally change how simulation is used in medical training. Not replacing residency, not replacing clinical training, but providing a simulation substrate for skill development that is available on demand, infinitely scalable, and calibrated to the specific learning needs of the individual trainee. For specialties like regenerative medicine, where formal training pathways are informal and evidence is moving fast, AI-based simulation training will be the continuing medical education format of the 2030s. A fellow who wants to develop their clinical judgment on PRP protocol selection across 100 different patient profiles will be able to run those cases in a simulated environment before the next clinic day. That capability does not exist in any organized form today. It will by 2030. I want to give you 3 questions that I think are the most valuable questions to be asking right now, in 2026, across 3 different roles. If you're a clinician or practice owner, what is my documentation overhead per visit in minutes, and what would a 30% reduction in that overhead allow me to do with my practice? This is the starting calculation. If the answer is not much, if you are already optimally efficient, then clinical AI is a lower priority. If the answer is, I would see 5 more patients a week, or I would have time to develop the teleconsult program I have been thinking about, or I would actually take a vacation, then the investment case for documentation automation is clear. Start there. Build from zone 1 of the playbook. If you are a healthcare operator or technology decision maker, does this AI tool have an explicit physician review gate at every consequential action? And is that gate enforced architecturally or just by policy? This is the question that separates the safety engineered tools from the ones that are safety marketed. Policy means the AI is told to stay in its lane. Architecture means the lane is structurally enforced. You want architecture. If you are a patient, has your doctor's practice adopted any AI-assisted tools for documentation, care coordination, or clinical decision support? And if so, what is the physician's role in reviewing their outputs? You have a legitimate interest in this question. You are entitled to know whether the care plan you received was generated with AI assistance and reviewed by your physician, or generated by your physician independently. Both can produce good care. The transparency about which approach is being used is a reasonable expectation. I want to be specific about Pravida's direction, because I think the most credible content is content where the host has skin in the game. Over the next 18 months, Pravida's operational priority is documentation automation and outcome tracking infrastructure. That is Zone 1 and Zone 5 of the playbook from Episode 8. Those are the highest ROI investments for a practice at our stage, and they are buildable with current tools. We are in active evaluation of ambient documentation tools and assessing which ones have the EHR integration maturity and the physician review architecture that meet the standards I described in this series. In parallel, I am building the clinical content infrastructure, this YouTube series is part of that, to position Pravida as the leading voice in regenerative medicine clinical AI. That is not just a marketing decision, it is a patient education commitment. The patients who will benefit most from the clinical advances I have described in this series are the patients who understand what those advances are and can advocate for access to them. Helping patients develop that understanding is part of what a physician educator owes to the field. Longer term, the Phase 3 build I described in Episode 8, the Pravida AI operating system will be a composable, manifested longitudinal record that tracks outcomes at the protocol level, identifies response patterns across our patient population, and provides a structured evidence base for protocol refinement. That is the clinical research infrastructure that a practice like ours needs to contribute meaningfully to the evidence base in regenerative medicine. It is also the asset that positions us for federal contracting and partnership opportunities. I do not think this roadmap is unique to Pravida. I think it is the right roadmap for any specialty practice that is serious about operating in the clinical AI era. The tools are available, the architecture is described, the business case is clear. What is required is the will to build toward it systematically, rather than waiting for an off-the-shelf product that perfectly solves your specific workflow. Any 5-year forecast in a fast-moving technical field should come with a list of the things the forecaster genuinely does not know. Here is mine. I do not know how quickly the FDA will develop a clear regulatory framework for agentic clinical AI tools. The current guidance on software as a medical device is being updated, but the specific question of how AI agents that take multi-step clinical actions are regulated is not yet resolved. That regulatory uncertainty is a real drag on investment and deployment, and I cannot predict when it resolves. I do not know how the liability framework evolves. Right now, the legal consensus, such as it is that the physician is accountable for clinical decisions supported by AI tools, just as the physician is accountable for decisions based on any other clinical tool. But as AI tools become more capable and their outputs more authoritative, that consensus may shift. The legal question of who bears liability when an AI's recommendation contributes to a patient harm is one that the courts have not yet fully addressed. I do not know how quickly the outcome data emerges. The Google AMIE real-world virtual care study, the Hippocratic AI health system deployments, the Tairex virtual consultation room. Those are the sources that will produce the clinical outcome data that changes the regulatory and liability conversations. I do not know how soon that data will be mature enough to draw conclusions, or whether the conclusions will be as favorable as the benchmark data suggests. And I do not know how the physician workforce responds. The adoption curve for clinical AI depends not just on the technology and the regulation, but on whether the physician community engages with it seriously as both user and critic, or retreats into skepticism. I am making a bet with this series that the physicians who engage seriously will be better positioned than those who do not. I believe that bet is correct. I acknowledge it is a bet. 10 episodes, 10 weeks. One thesis: medicine is getting an operating system, and the clinicians who understand that thesis, who can read the architecture papers, evaluate the benchmark claims, design the physician review gates, and build toward the playbook, will practice better medicine. The research is real. The architecture is sound. The deployment is early. The safety requirements are non-negotiable. The opportunity for specialty medicine, for practices like Pravida, doing highly individualized longitudinal evidence frontier work, is enormous. Precisely because the big labs and the big EHR vendors are not building for us. Thank you for being part of this series. If you found it valuable, share it with a colleague, a fellow physician, a practice manager, a medical student who is wondering what their career is going to look like. The conversation this series is trying to start is one that the medical community needs to be having at the practice level. Subscribe, because we are not done. Season 2 of the Medical Operating System launches next quarter. The theme is Agentic AI for longevity medicine. We are going to go deep on biological age assessment, multi-omic data integration, and longitudinal biomarker tracking. Season 2 is where we apply the foundation to the frontier. Until then, ask hard questions, read the methods sections, and keep the physician in the loop. I'm Dr. Trevor Turner. This is the Medical Operating System.